there have been a number of very important advances here, or rather advances reported. And what I'm particularly excited about is the immunotherapy that's been discussed, recognizing that immune therapy has been part of what we've been doing for the last 15 years. If I may, what's captured your imagination as an attendee, a patient who's highly informed? What's captured your imagination at the meeting?
The diversity of research, and that we have to basically search everything, and everybody does, and so everybody tries to share their research, but it's so diverse that we still don't really know which one is going to lead to the cure.
But those are good things, because as you pointed out, if you have 5,000 mutations at diagnosis, 12,000 at relapse, the more the merrier. And you need to throw a net around this disease very quickly. And I think we touched on this at the meeting with not just the monoclonal antibodies, the checkpoint inhibitors, immune modulation, proteasome inhibition, but very excitingly as well, this whole construct of how unleashing the immune system is a very effective way of beating this disease.
When you go through a stem cell transplant, as you know, and you take a Melphalan, it basically sort of resets your immune system.
Exactly.
But what do we know about the new immune system going as bad as the old one? Is it a gene issue? Is it the way you live? So I do believe in the body and in your own immune system, finding out one day that you have a problem, and your immune system being the police of your body, trying to go after the bad guys. So how do you wake him up, or how do you really sort of point in the direction of the right bad guys in your body? And that's the issue also that you have when you do a third-party stem cell transplant. How do you know that the stem cells you're going to get are going to target the bad guys versus the good guys?
Right, and that touches on a very interesting point, which we perhaps could spend a little bit of time on. Taking cells from someone else, a so-called allogeneic stem cell transplant, very curative in other diseases. In myeloma, more challenging. And I think that the real problem is what we call graft versus host disease, where the disease turns on the host, or rather, I apologize, the immune system that's given turns on the patient. The issue for myeloma, I think, is because that's been so challenging, whilst you never stop evaluating allo transplant and assessing it, it tells us that we need to think also out of the box. We need to think very differently. And
that's why we want fundamental research and new types of research.
Exactly, and I think that the success with immune therapies in myeloma in other ways points in a new direction. We realize that the immunomodulatory drugs have been immunotherapy for the last 15 years. Very different and very important, and without the side effects of allotransplant. You touched on high-dose Melphalan resetting the immune system. It does. But as we discussed at this meeting, it's an old warhorse that we've used for many years and has side effects in the long term that can become a real problem, secondary leukemia. So being that the case, we need to think about how do we reset the immune system without those issues.
And which is the same issue if you take maintenance therapy, which sort of brings down your immune system, then many other cancer can arise.
Well, yes, although we've learned a lot about that. We've learned that, for example, if you take lenalidomide as maintenance, continually being on it results in survival benefit. And you're an example of this now. You're on your RBD and you're staying on the maintenance, and it's suiting you very well. I think that's a very, very important message, because whilst there are side effects from lenalidomide that we worry about, what we've realized is, fortunately, they're very rare, and actually their relationship is linked to Melphalan. If you've had Melphalan, the risk of these second cancers goes up. If you haven't had Melphalan, the risk is much lower. So these are all important considerations, and I think what's exciting and what's important to share for our patients is that, and our viewers obviously, is that we need to be thinking in a very different context. Not just what's immediately going to help, but how can we help you, Vivien, 10, 15, 20 years down the road?
That's what I love about this disease, and that's why I'm actually feeling very lucky I have it. Not only because I can maybe help, and maybe that's my purpose in my life, but also because intellectually it's extremely challenging. And I think this is the cancer you want to have if you are a bit interested in what you're doing or when you're getting. And so it's captivating. And so that's why I'm so involved, and I want to participate more and more so.